Let's jump right into today's explainer, where we're unpacking the critical pathways and treatment protocols for rhabdomyolysis. We're keeping the focus tight, incredibly detailed, and completely actionable. If you want to understand exactly what happens when skeletal muscle breaks down, and more importantly, how to save the kidneys when it does, you are absolutely in the right place. We're going to go point by point here so you don't miss a single crucial detail. Today's agenda covers 1. Background and pathophysiology. 2. Causes and epidemiology. 3. Predicting acute kidney injury. 4. Core management and treatment. And finally, 5. Advanced treatment adjuncts. Section 1. Background and pathophysiology. The cellular breakdown. So to really grasp this, you gotta think of the muscle cell like a dam. When skeletal muscle gets injured, that cellular wall breaks, and a bursted dam causes a massive toxic flood right into the plasma. We're talking about intracellular contents, things like potassium, phosphate, CPK, urate, and myoglobin, all rushing directly into the bloodstream. And this specific cocktail, it is highly, highly toxic to the renal system. Clinically, how is this going to present? Well, if you see this classic triad in a patient, your diagnostic alarms need to start ringing immediately. We're looking for muscle weakness, myalgias, which is severe muscle pain, and dark urine. That dark urine is actually a direct visual indicator. It literally shows you those intracellular contents, specifically myoglobin, spilling right out of the body. Now, it's fascinating to contrast our two main biomarkers, because it reveals exactly why we use them so differently. Myoglobin clears out fast, usually within 24 hours, and it's the bad actor causing direct renal toxicity. CPK, on the other hand, kind of lags behind. It peaks at 24 to 36 hours. Because of that delay, CPK is our true marker for injury severity, which makes it our incredibly reliable diagnostic gauge even long after the myoglobin has vanished from the radar. Okay, let's break down how this builds a literal perfect storm for renal failure, step by destructive step. Acute kidney injury in this context happens through 3 primary mechanisms. Step 1. Decreased extracellular volume combined with vasoactive substances causes severe renal vasoconstriction. Step 2. Myoglobin hits an acidic environment in the kidneys, specifically any pH less than 5.6, and it forms a highly toxic substance called ferrihematite. Step 3, that initial vasoconstriction causes ischemia, depleting renal tubule ATP formation. This enhances tubular cell damage, and when combined with myoglobin precipitation, it forms dense obstructive casts right there in the tubules. It's a cascading disaster. Section 2, causes and epidemiology. Who gets it and why? So who actually gets rhabdomyolysis? Naturally, we all think of trauma and massive crush injuries first. But listen, neurosurgeons are incredibly likely to encounter this during prolonged operations, especially prone spine surgeries. Beyond the OR, we absolutely have to cast a wide net for non-traumatic causes. You need to be looking out for infections, certain drugs, alcohol abuse, various toxins, extreme muscular activity, and even sickle cell trait. And the stakes here are severe. When we look at myoglobin-induced acute kidney injury across all those causes, 32% of adult patients will suffer kidney damage severe enough to require short-term hemodialysis. Think about that. Roughly a third of these patients will temporarily lose their kidney function entirely. Astonishingly, when you look at the grand scheme of hospital care, rhabdomyolysis is not just some fringe issue. It actually accounts for up to 20% of all adult cases of acute kidney injury. Section 3. Predicting acute kidney injury. Red flags. You have to keep a very, very close eye on these compounding factors. A peak CPK over 6,000 is your first major warning sign. But dehydration is a massive accelerator that speeds up precipitation in the kidneys. And we define dehydration here specifically as a hematocrit over 50 and serum sodium greater than 150 milliequivalents per liter. Add to that the presence of sepsis, hypokalemia, or hyperphosphatemia right on admission, or hypoalbuminemia, and you drastically multiply the risk of acute injury. Now, while renal injury risk is generally lower when those initial CPK levels are down, crossing a threshold of 15,000 means acute kidney injury is highly, highly imminent, especially if dehydration or sepsis is already in the mix. That's your absolute danger zone. Section 4. Core management and treatment. The rescue protocol. Right, so the diagnosis is made. We start with a meticulous general protocol. Step 1, secure the ABCs, monitor input and output with a Foley catheter, and aggressively correct those electrolytes. Step 2, Minimize stressors immediately by stopping nephrotoxic drugs, like NSAIDs, to protect the patient from further iatrogenic harm. And step 3, if hyperkalemia is present, run an EKG right away. Do not wait on that. To put it as simply as possible, dilution is the solution to pollution. The absolute mainstay of our treatment is rapid expansion of extracellular volume. Doing this accomplishes 3 critical things simultaneously. It increases the glomerular filtration rate, it delivers much-needed oxygen to ischemic tissues, and it dilutes those myoglobin toxins that are actively trying to precipitate in the kidneys. But what fluid do we actually use? Well, lactated Ringer's is explicitly preferred over normal saline for IV fluid resuscitation here. And you really need to memorize this specific urine output target. Your absolute goal is to maintain a urine output of greater than or equal to 1 milliliter per kilogram per hour. Hitting that specific target proves your volume expansion is actually working, and you're successfully flushing the kidneys. Section 5. Advanced treatment adjuncts beyond IV fluids. If volume expansion alone just isn't cutting it, we rely on specific fluid mixtures based entirely on the patient's sodium levels to alkalinize the urine. This table is basically a lifesaver. If serum sodium is less than or equal to 147, you mix half normal saline with 100 milliequivalents of sodium bicarbonate per liter running at 125 mils an hour. Now, if sodium is over 147, you switch the base fluid to D5W with that exact same bicarb dose. Alongside this, you also have the option to administer mannitol at 12.5 grams IV every 6 hours as an adjunct. But listen, you must monitor this bicarb therapy meticulously. Patients need daily arterial blood gas and electrolyte checks. If the serum pH drops below 715, you give a 100 milliequivalent bolus of bicarb. However, you absolutely must discontinue the bicarbonate entirely if the pH hits 7.5 or higher. Remember, we want to alkalinize the urine to prevent that toxic ferrihemate formation, but pushing the blood pH too high creates entirely new dangerous problems. And critically, always hold the sodium bicarb if the patient develops hypernatremia. Here's a great clinical pearl regarding monitoring, and it'll save everyone a headache. Serial CPK measurements are not required after the peak is passed. This saves time, saves resources, and saves the patient from extra needle sticks. Once that CPK number stops climbing and starts steadily dropping, you do not need to keep checking it compulsively. But what happens if everything we've done fails? If volume expansion and bicarbonate fail, we look for 4 specific severe complications that dictate an immediate pivot to mechanical dialysis. We're looking for oliguric renal failure, where they simply aren't making urine, persistent hyperkalemia that won't resolve, fluid overload leading to pulmonary edema or congestive heart failure, and persistent metabolic acidosis. Dialysis becomes the necessary final resort to clear out the toxins and the excess fluid. As we wrap up, I want you to think back to those at-risk groups we talked about earlier. For patients undergoing things like spine surgery lasting over 5 hours, proactive intervention is the key. Checking CPK and myoglobin levels post-op and aggressively hydrating them early if those levels are elevated can stop this full-blown syndrome from ever developing. It really leaves you wondering how many severe AKI cases could be entirely avoided with just a little proactive intervention, doesn't it? Thank you for joining me on this explainer. Stay curious, stay structured, and I'll catch you in the next one.